Hello, everyone, and welcome to ACP's live remote non-CE offering. ACP's live remote webinar series includes both CE and non-CE instruction and has been launched to provide additional remote resources and outreach to our facility partners. Today's non-CE topic is the science behind electrotherapy for functional re-education. I would like to introduce our speaker for today, Ron Volan, physical therapist and clinical program consultant with ACP.
Hello, everybody. Thank you for joining today. My name is Ron Volan. I'm a physical therapist. I have been with Accelerated Care Plus now for almost 5 years, and I work in the New York metropolitan area. Today's discussion is going to be focusing on the use of electrotherapy, but specifically neuromuscular electrical stimulation. And that is a method of being able to use e-stim for the purpose of facilitating muscle contraction, but more specific than that, is we're using it with the intent of being able to help facilitate movement, and that movement will result in functional activity. So it's really combining neuromuscular electrical stimulation with functional training into one activity. And there's a few reasons why I think that may be of value to consider. To begin with, just as a simple definition, functional electrical stimulation, according to Wikipedia, is stimulation of technique that uses low energy electrical pulses to artificially generate body movements in individuals who have been paralyzed due to injury to the central nervous system. And without a doubt, that definition sums up most of the research that's available with regards to this technique. But I would say that that may be a little bit narrow in terms of the definition of how it could be used, because in fact, if you think about the fact that these same techniques are used even in the case of athletes who are recovering from injury, I think we could make the case that FES could be used for a variety of different applications that don't require paralysis or injury to the central nervous system. Our discussion, though, will focus on those specific conditions. And there will be a few pieces that we discuss that may deviate a bit, but most of it will surround either stroke or spinal cord injury, because those are the areas that have received the most attention with regards to the research. And our purpose today is to focus on the research that surrounds these techniques and its different applications. And then, in addition, there will be other trainings and other training that's more geared towards the practical aspects of how to use the ACP equipment to be able to facilitate FES. This is more the scientific evidence behind it, all right? Looking at different methods of application of electrical stimulation for FES, we have a couple of techniques that we're less likely to encounter in the clinic. One is the use of a percutaneous nerve stimulator. A percutaneous nerve stimulator is a device where you have an electrode that's implanted under the skin. It will allow you to deliver the electrical stimulation directly to the target nerve or to the area immediately adjacent to it, which means you're a bit more specific and targeted with regards to that application. When we talk about use of electrodes over the skin, it's hard sometimes to get your position proper and precise with each application. Percutaneous nerve stimulators really allow you to be quite precise and maintain a consistent application with each treatment. The problem is, it's a surgical procedure, a simple one, to be able to install it, and it's certainly subject to some complications with regards to the electrodes coming out or infection forming. So that's one option. Another is the use of an implanted stimulator. An implanted stimulator actually is a self-contained device that gets implanted into the body and delivers the stimulus directly to usually the spinal cord or the epidural space or the nerves from the spine. And the benefit of this is that it's all a self-contained device with battery included, so that it makes it much more portable and much more usable in a variety of different contexts. However, it's a complicated procedure to install it. It's surgery, it's not minor surgery. And as a result, the applications for this type of treatment for FES have largely been limited to people with more severe paralysis resulting from spinal cord injury. There is a company in Switzerland called, used to be called G-Force Therapeutics, it's now GTX, and they actually have developed a very unique system made by Medtronic that gets implanted into the spine and has had really good results in the last year, helping people with incomplete spinal cord injury be able to stand and walk for extended distances with good efficiency. So that's something to look forward to in the future as the technology evolves. We're going to be discussing primarily the use of transcutaneous electrical stimulation. And that means that we have 2 electrodes or more that will be delivering a charge through the skin to the adjacent tissue to help cause stimulation of the nerve. And it could be either sensory or motor nerve that then causes the muscle to contract. There are 2 different variations within this concept of using FES. One we would refer to as an open loop system. And the open loop system either has a trigger device that applies the stimulus by a therapist, right? And the therapist is going to say on or off, depending upon their timing that they're seeking with regards to it. Very good for training. You can then incorporate the stimulation as part of the training process into the activity as a skilled technique. But it's not very adaptable beyond the therapy context, of course. Another option is using what we call a cyclic stimulation. And a cyclic stimulation allows the therapist to be able to set parameters on and off in a cycle, right? And it can be done either in an even reciprocal type stimulation where you're going to go on, off. Reciprocal alternating movements such as cycle and walking would be examples of that. Or it may end up being a set discrete on and off phase, for instance, 10 seconds on, followed by 50 seconds off, in which case you're going to be trying to coordinate the movements that you're seeking to replicate around that preset cycle, whatever it may be. Sometimes that may be constraining because it's not responsive to changes in timing or movement. So a closed loop system then is a system that does have the ability to adapt to the individual needs of that movement at that time. How does it do that? It uses sensors. An example of a sensor might be a pressure switch, which is a common application for this purpose of putting, for instance, a pressure pad into the heel of a shoe, and then the pressure on and off of that pad turns the stimulation on and off according to the gait cycle. Another would be using an accelerometer in the same context, putting it in a vicinity of the joint, and changes in position of that joint would be registered by the change of position of the accelerometer, and it would deactivate and activate the stimulus appropriately. And the final is using EMG sensors, where you can actually implant the sensor near the point of stimulation so that that individual, when they go to use a specific muscle that they would normally use to, say, for instance, open their hand, they can do a partial movement. The EMG sensor detects that movement and then amplifies it to be able to give a full extension. I have an example of that so that you can see what that would look like. All right. When we talk about being able to use FES, why is it different from doing, for instance, electrical stimulation without the functional activity? And the answer is because research that's evaluated the use of FES compared to doing active movement by itself, compared to doing electrical stimulation by itself, found that when you combine the 2 pieces together, the FES and the E-stim by itself, right, it's going to affect a couple of parameters of exercise that you may not be able to do without the E-stim as effectively. You can control parameters such as the duration of a muscle contraction, the intensity of that muscle contraction, as well as the timing frequency pieces, right? You have the ability to control all of those pieces through setup. When a person is initiating movement on their own, it's much more difficult to get compliance with regards to the targets with regards to those pieces. And those pieces of timing, intensity, duration, all of those are critically important for neuroplasticity, which is changes in the processing of the brain processing and the stimulation of the cortex. So FES combines the benefits of E-stim with the benefits of having an intentional movement, which of course is another critical component of neuroplasticity. And therefore, the research that's looked at these comparisons between E-stim, voluntary activity, and the 2 combined has found that when you combine the 2 into FES, you get significantly more substantial brain activation that indicates that we're getting that neuroplastic effect that we're seeking. Another way to help evaluate how this tool may be of value in the clinic is to look at the clinical practice guidelines that are available. And there are several of them. I've pulled 3 prominent ones out. One comes from the U.S. Veterans Administration, Department of Defense, where they evaluated the use of FES, and it's a fairly large body of research with this, to determine its efficacy for treatment of stroke. And their clinical practice guideline recommends both the application of FES for management of shoulder girdle strengthening and subluxation, as well as for being able to help improve control to the knee and ankle to help facilitate improvements of gait for patients with stroke. Similarly, the Canadian Partnership for Stroke Recovery, which is associated with the National Healthcare System, has published a very comprehensive review of research associated with stroke in all of its manifestations, not just rehab techniques. And if you see this research, it's evidence-based review of stroke recovery, quite comprehensive. It also advocates for the use of FES to help improve, again, upper extremity activities such as grasp and manipulation, as well as lower extremity activities such as ambulation. And finally, NICE, which is the National Institute for Healthcare Excellence in the United Kingdom, also directly associated with the National Healthcare System, has also recommended the use of FES for treatment of drop foot to help improve gait. So those are pretty compelling reasons why we may want to consider applying these techniques, especially for our patients with central nervous system injuries, such as stroke, spinal cord injury, multiple sclerosis, and brain injury. However, there was research recently completed, this was in Canada, where they received survey responses from almost 300 therapists to the question of how often FES was integrated into their clinical practice. They were across the spectrum of different practice environments. And across the board, as you can see from all of these different specific applications, the number of therapists who incorporated FES, even if we expanded it to the category of sometimes, frequently, or most of the time, was less than 20%. And that means that 80% used it occasionally, rarely, or never. And that's quite a significant difference between the research-based evidence supporting these applications, the clinical practice guidelines advocating for them, and the actual practice of it. And the observation that they made from the results of their survey is that most respondents would like to increase their use of FES, but to do so, they have to improve access to necessary resources such as education, as well as devices that are user-friendly and time-efficient. So that really sums up the purpose of this training, which is to help provide the educational component that we're looking for with regards to understanding how it can be used and the evidence behind it. All right, so using electrical stimulation for facilitation of gait is probably the oldest researched method, and the primary method that has been used for that purpose is peroneal nerve stimulation. And the purpose of peroneal nerve stimulation is to be able to help activate dorsiflexion of the foot so that for patients who have foot drop or weakness of ankle dorsiflexion, they have lower risk of stumbling or tripping or falling as a result of that weakness, right? And so it's been used since the early 60s. There's quite a bit of research that's been done, and there are quite a few devices that have developed over the course of time to help facilitate this. There have been several systematic reviews that have identified the value of using FES for the purpose of being able to help facilitate dorsiflexion and improve gait dynamics. However, when you compare that technique to the use of an AFO, sadly, they really are fairly similar in terms of their results. And the problem is that an AFO as a passive device is far less expensive than using a stimulation device. And as a result, there are very few funding sources for being able to use this type of FES device because of the cost differential. The problem with the AFO is passive, which means that in terms of being able to facilitate improved motor control or increased strength, it really doesn't offer that as an option. Whereas the use of peripheral nerve stimulation certainly does have the potential to improve strength or coordination or timing, which becomes a critical factor for actual rehabilitation. I will give you an example quickly, and I have to deviate from my presentation quickly for this, of how this might look. This is a woman with multiple sclerosis. This is actually the first time that she's used the walk aid. This comes from a much longer video, but the differences in terms of her movement are pretty clear. This is with the walk aid immediately following. Using an accelerometer there to help detect changes in position to activate dorsiflexion on time. So, you know, not every patient is going to have the same response. So obviously there can be quite a bit of variation with upper motor neuron injuries. Another option, similar category, is using a two-channel system. A two-channel system incorporates both the peroneal nerve stimulator as well as the stimulation of the gastrocsoleus complex. And the idea here is that we're stimulating in coordination with the normal timing of activation of those muscle groups. And you get a benefit from this that you don't get from the stimulation primarily of anterior tibial muscle, which is that by stimulating the gastrocsoleus, you get an increase with regard to propulsion. And for patients post-CVA, when they've done research with the integration of the stimulation of gastrocsoleus, these patients show significant improvement in speed, as well as their distance for 6-minute walk test, and general measures of energy efficiency, so improvement when you integrate the two. There's also some thought, and I don't think that this is well proven yet, that by stimulating the anterior tibialis muscle, coordinated with stimulation of the gastroc, you're controlling timing and you're helping to deactivate the gastroc when it becomes spastic with weight bearing. So there might be some really interesting opportunities with this technique. It's been researched for the past 10 years and showing good results. An interesting side journey from this original research is that they found that several patients who were getting this treatment by the end of the research studies had, for those who had had significant decrease of circulation in their feet, ended up having reduced symptoms of pain and claudication, indicating that the treatment not only improved their neuromuscular control and their ambulation skill, but also facilitated improvements with regards to circulation, which was revealed by another study in 2017 that focused on changes of circulation with this time of treatment. So just some interesting work there. Another step up from this is to consider a multi-channel system, the most common being a 4-channel system that looks at stimulation of the tibialis anterior, gastroc, quadricep, and hamstring, using the timings that would normally be recruited for gait. And again, most of this work has been done with patients post-CVA. And while there has been some evidence indicating that it shows significant improvement with regards to sequence of gait, I would say that there are significant practicality issues with being able to use this in the clinic, because it's a complicated system that requires quite a sophisticated simulation device and computerization. As this technique maybe becomes more miniaturized with microprocessors moving forward, maybe we could see this integrated better into the clinic. All right, we're going to move on now to looking at applications for upper extremity, and they are quite varied. So applications for upper extremity could incorporate stabilization of the scapula, reduction of subluxation, elevation of the arm, flexion and extension of the elbow, flexion extension of the wrist, as well as incorporating grasp and release function.
With the arm dangling over the edge, where you're having to really fire this muscle. Okay. All right, Britta, what we're going to do is you're going to start with your arm in this position here. When you feel the stim, I want you to pull your shoulder blade up and back and pull your arm up to your body. When the stim turns off, you're going to let your arm come back down. I'm looking for you to access these muscles right here where the electrodes are. Okay. I'm going to wait for your cue. I'm going to guide you through it too. So when you feel stim, I want you to initiate the movement. Okay.
Just hold it up there till the stim stops?
Yep, and then when it stops, you're going to let it come back down. You get a couple second break, and then you do it again. And I release all the way down. I don't want you to pull from here. I want the shoulder hiking toward your ear. I want everything pulling down and back, which is why I'm kind of guiding you down this way. Shoulders okay? Pain and all?
No.
Is there a stretch in the front?
Stretch in the whole front of my arm.
Yeah.
Like from my elbow down to my pinky.
Okay.
Stretch, but not a painful stretch.
Good.
The stim is on and now it's off. On.
Good work with me. Pull it up. Find that shoulder blade. Pull that shoulder blade down and back.
I think that gives a pretty good indication of how this can be used as a skilled treatment. and how it can be used to help educate the patient with regards to how to perform a movement and what muscles to use, both as a sensory feedback as well as facilitation of motor response. This next one uses that concept I mentioned earlier of an EMG feedback. Now, this is one of the first times that this gentleman is using this device, but he's 6 years post-CVA.
I'm going to attempt to lift up my pickup stick for the first time 6 years after having a major ischemic stroke. My brain is doing this on its own. There's no triggers, there's no timers. I have to go through all the brain damage, 33%, to send the message to my left hand. So I'm relaxing my shoulder, my forearm. On a count of 3, I'm going to lift the stick up. So 1, 2, 3. Now I'm going to release it by counting 1, 2, 3. My hand is open. I'm putting it down. Okay, 1, 2, 3, open hand. Put it down to relax. Just need to relax the shoulder and arm. I'm going to remember that. So again, on the count of 3, 1, 2, 3. My hand opened up a little early there because I thought about it and it sent that signal down quicker than I thought. So again, I'm just thinking about opening my hand up and it's opening. I'm not actually forcing it. So right now I'm just thinking in my head. And this will take 600 repetitions to do. I know that the hard work is going to happen this year, and eventually I'll build neuro pathways and neuroplasticity in my brain to rebuild the brain damage to get around it, to get my hand to open and close like my other hand. The grip will come over time, but you've got to keep practicing, and that's what I'm doing every day, and I'm going to do it.
It's hard to see the effect there as well, but I liked his description of it. So those are a couple of examples for upper extremity. And the problem with the upper extremity research is that it's quite varied as far as the different studies that have been done. There are so many different applications that I wouldn't say there's as much obvious consensus as you have from the as to the lower extremity and gait-related activities. So there has been a systematic review that was done recently with regards to applications of FES for upper extremity, looked at quite a few different studies that have used the techniques. And if you look at the results of this on the display, if you look at on the right side of the screen of that data graph, that there is a vertical line with horizontal lines going through it. Each of those horizontal lines is a study. And to the extent that the green line falls on the right side of that vertical line, it indicates that the study showed significant benefit relative to the application of FES. And you can see that the vast majority of studies did do just that. So the recommendation from this review was that FES for upper extremity applications after stroke is particularly valuable, especially in the earlier stages. Some of the chronic studies were not as well controlled with that regard. All right. And next, we're going to look at applications that have to do with use of electrical stimulation and functional electric stimulation to help facilitate exercise. And the most common application for this is doing cycle exercise. Obviously, what we get here moves beyond just the functional capacity and starts to move into some of the physiological benefits that we get from exercise. And I found a really articulate and interesting TED Talk where a gentleman with tetraplegia goes into a good description.
Exactly like the other one. You see the electrodes on my legs. You see on my quadriceps, on my hamstrings, ischial, and also in my buttocks and my fascia. All that helps me to pedal, but it also helps me to build my muscles. Not to be pretty, but to protect myself from pressure sores, escar. which is something that's very, very important for us. Us meaning those who sit in wheelchairs all day. So this activity doesn't only just bring me pleasure, it's very important for my health. And for anyone who sits in a wheelchair all day, they should be doing this. And we're doing all possible for us to be able to make that possible for them. And if you think about this, and we have a bit, bicycling's not the only thing we can do. There's actually something even simpler, and that's rowing. And here you're looking at our new sports room, where we're putting all of these devices together and offering people to come work out. And you see a rowing machine that it's extremely simple because it's just moving back and forward, attaching the electrodes, as you can see, to Julian's legs. Julian's my friend. By the way, you wouldn't know it by looking at him, but he's tetraplegic. Look at the size of his muscles. It's pretty impressive. He does a lot of bike riding. Well, FES bike riding. But he's also starting to do a lot of rowing. Now, there is an advantage to the rowing. The rowing offers also cardiovascular workout because you're able to pull and work your upper body at the same time. So it's a complementary workout to the bike.
I encourage you to explore these videos in their entirety because especially that one is super interesting in terms of his presentation and the knowledge he brings to it. But that concept of being able to integrate into both cycling as well as rowing, I think is a really compelling, and I think both of those can be easily integrated into clinical practice. All right, so there are just a couple of more applications that we may consider with regards to FES. One is being able to use functional electrical stimulation to help improve respiratory function. And for this, we have a much more narrow spectrum of research that's been done on it. Specifically, it was looking at stimulation of the abdominal muscles for patients, again, with spinal cord injury, and specifically patients with tetraplegia. And so it was patients who had impaired respiratory function secondary to their paralysis. And it was looking both acute and chronic at the effects of FES, and specifically in the acute case, they were looking at whether the FES could help facilitate their respiratory status. And the results of this, they did, I think there were 8 studies that were incorporated into the systematic review on this topic, found that there were significant improvements in respiratory function, including measurements of pulmonary function, as well as improvements in terms of being able to have patients transition away from use of assisted ventilation, which I thought was pretty interesting. And the curious thing about that is that that concept of stimulating the abdominals is specific to being able to help improve expiration, right? And there are other diseases where there may be value to being able to help facilitate increased strength of respiration, right? Where people have impairments of, being able to get all of the air out of their lungs in the case of COPD, or impairments with regards to the strength of cough for airway clearance, or being able to clear their throat, being able to help reduce risk of aspiration. But there hasn't been research yet with regards to the application of these techniques for those other populations that I've located, just for the spinal cord. But it's an interesting area of research for the future, I hope. Finally, another concept of FES is that you could incorporate it with the treatment of patients with urinary incontinence. My point of view on this is that pelvic floor muscle strengthening is probably the most important element for being able to help reduce the effects of stress, urge, and mixed incontinence. However, electrical stimulation can again significantly increase the strength of contraction and also provide a level of training for people who are trying to learn how to activate their pelvic floor muscles, and therefore may offer an excellent adjunct in order to help improve pelvic floor strength and being able to get then reduction of incontinence. There had been a Cochrane review that looked at this specific technique and indicated that the use of E-stim is likely to be more effective than no treatment or sham treatment, but not necessarily superior to pelvic floor muscle training. And I, again, wouldn't think of doing them separately. I would think of combining those two together into FES by using electrical stimulation with pelvic floor muscle strengthening in order to get that better combined effect. But that may be another application to continue to consider. There are others that have been investigated, but with much less specific method, such as being able to use electrical stimulation to help improve trunk stabilization and balance. But that hasn't coalesced into a clear enough protocol or sequence of studies to be able to draw a conclusion from it. And I suspect that there are others as well, but I just wanted to cover these primary methods in order to help create a clearer idea as to how to start using these techniques in the clinic immediately. If you have questions with regards to how to apply these techniques, I would urge you to reach out to your clinical program consultant from ACP, who will be able to provide excellent ideas for how to use it in the context of your specific treatment goals. And thank you very much for joining.
Thank you so much, Ron, for that excellent presentation. I think it was very informative, and hopefully everyone now has a better understanding of functional electrical stimulation, as well as how to apply it in different scenarios with different patient populations. As Ron mentioned, please feel free to contact your clinical program consultant if you have any additional questions. You can also contact ACP Remote Clinical Support at 800-250-1100, extension 2, or via email at acp-clinicalquestions@hanger.com. Thank you so much for your time today. Have a fantastic day and stay safe and healthy.
Thank you.